Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning for everyone. Good evening for those people in another part of the world. And today I'm very happy that we start this year for the first webinar for the Biotechnology, Science, Business, and Society in Institute of Bioproducts Development. My name is Hisham. I'm a director of Institute of Bioproducts Development. And today we have a very special guest. We have Dr. MARIAM BOTROS from Canada. And before we start, I'm just giving some info about our honorable speaker today. Dr. MARIAM is a Chief Executive Officer of the WONS Canada. She is responsible for both of implementation of strategic direction and day-to-day operation of the organization. She is a chiropodist and diabetes educators by training and completed her master educational leadership. Dr. MARIAM has also published and developed and lectured in multiple programs, both nationally and internationally. She is also the vice president of D-Food International. Through her different roles as an executive director, healthcare practitioners, and educators, researcher, and faculty member for many well-organized, recognized organizations. Dr. MARIAM has extensive practical and professional experience in advancing public health policy and is respected as a strategic visionary and system thinker. Thank you very much, Dr. MARIAM, for accepting our invitation, for being our first guest of the year for our webinars in IBD UTM. Thank you very much, Dr. MARIAM, and we are all waiting to hear your very interesting lecture, which is, I think it's a combination between basic science and applied science, which is tackling a very important topic nowadays about the wound healing. Thank you very much, Dr. MARIAM, and we are all waiting for you.
Thank you so much, Dr. Hisham. It's an honor to be here with you and to speak to you on a topic that's quite close to my heart, wound care, and what to put on an oozing wound, the mechanical and contact characteristics of foam dressings. So I'll just upload the slides and we'll start with this session. And I really welcome all your questions at the end. And I look forward to quite an interactive session with you. Thank you. No. Can you see my slides so far? Sorry for the small technical glitch, but we'll be up and running quickly. All right. Thank you. Can you see my slides, Dr. Hisham?
No, please share it again so we can see the slides.
Okay. How about now?
Now starting. Yes, we can see now the slides. Thank you.
Perfect. Thank you so much. So what to put on the oozing wound, the mechanical contact characteristics of foam dressings. So, as Dr. Hisham, thank you for the warm introduction. You now know who I am, and I haven't received any commercial interest from any company to do this presentation. So the objectives for this session, what we'll cover throughout the next half an hour will be, by the end of this session, you will be able to understand the benefits and drawbacks of wound exudate, discuss the management of wound exudate in persons living with diabetes, and summarize the characteristics of foam dressings and recognize resources available that can support your work and your practice. So I always like to start with a case study because ultimately everything we do is for that end consumer and patient that we all are passionate about treating and making a difference in their life. So I want you to meet Ali. He's a chef. He's 50 years old with diabetes mellitus. He has had diabetes for the last 20 years. He's divorced for the last 3 years, so a lot of social factors are coming into play. He comes to see you for a neuropathic diabetic foot ulcer. And right now, that wound has been heavily exudated for the last 4 weeks. And really, that's what brings him into clinic to see you, is all of that fluid that keeps coming out is why he's here to get help from you. He has good glycemic control for the purposes of this case study, but he has retinopathy, so his eyesight is impaired. And he has neuropathy, so he has lack of sensation on both feet. So that's Ali, and that's what he has. And he's here so that you can help him as a clinician and from a technology aspect. So whenever we consider a wound and somebody's coming to see us for a wound, it's really important that we address this in a very systematic way. We need to perform. So first of all, we're treating a person. We have to establish trust. I have to be able to form that trust with Ali, to be able to support him, see him, understand what his concerns are. And certainly for Ali, his major concern so far is that wound, that hole in his foot that keeps leaking fluid. So I'm going to perform a comprehensive assessment and identify any environmental and system challenges and identify risks and any causative factors that may impact his skin integrity and wound healing. I'm going to work very closely with Ali to set some goals to determine if that wound is healable or not. And certainly once we do that, we're also assisting in providing hope. And I'm going to assemble the right team members that can support Ali in assisting him. We're also going to implement a plan of care to support him locally with his wound care, that hole in his foot, and then connect him to the right resources, the right education, the right tools, the right people, the right dressings to support him. And then once he is all settled down, I'm going to be able to reevaluate Ali. So I wanted to have a closer look at the pathophysiology of why that wound is exudated. Is that normal? Is it abnormal? What's going on? So usually in any acute injury, we have localized or generalized inflammation affecting the wound. So, and that inflammation affects the wound. We have a release in the initial acute stages, a release of mediators and enzymes that create the vasodilation and increased capillary pressure. We start getting the breakdown of endothelial cell junctions. And we have breakdown and reduced stiffness of the extracellular matrix. And we start seeing the filtration of fluid, proteins, and cells into the interstitial fluids. And that's where a lot of our wound exudate accumulates. So that's how we get it. But that oozing for Ali hasn't just occurred over the last 2 weeks. The oozing has been progressive and increasing. And this is one of his main concerns, and that's why he's here to see you. Now, what does wound exudate in the initial stages do? Well, wound exudate in the initial stages is not a bad thing. It prevents the wound bed from drying out. So moist interactive wound healing is the ideal. So we don't want that wound to be too dry or too wet. So it's a good thing. It provides moisture. It aids in the migration of tissue repairing cells. It provides essential nutrients for that cell metabolism. It enables the diffusion of immune and growth factors. And it also assists separation of dead or damaged tissue, which is otherwise known as autolysis. So in the right amounts, wound exudate is not a bad thing for us. It's actually a good thing, and it is favorable. But in excess, it could become problematic. And in our case, it is starting to become problematic. So if in the initial stages, as you can see from this chart, in the initial stages of wound healing in the inflammatory stage, it's very helpful. But then if it continues on beyond the initial stages, it can become problematic, and we need to address it and we need to deal with it. And there are many factors that can lead wound exudate to become problematic or to have an increased exudate production, like local factors, infection, foreign body, edema, lymphatic dysfunction, wound bed sinus, wound bed fistula. All of these local factors can certainly affect it. And we can also have systemic factors that contribute to the increase of this exudate, like congestive, cardiac, renal, or hepatic failure, infection, endocrine disease, systemic medication, obesity, fluid overload, malnutrition, increased age, low serum albumin levels, raised C-reactive proteins. And then there are other practical factors like the wound positioning, where it's situated, where it's located, on the lower limbs, in the sacral area, heat. So in a geography such as yours, it could increase, especially in the lower limbs when it's situated. And then, of course, there's other factors, whereas reduced willingness or ability of the patient to cooperate with pharmacological or non-pharmacological treatments and inappropriate device intervention. So all of these can lead to it becoming problematic. So certainly with Ali, for the purposes of this case study, this case is the location of his wound, where, he's in closed shoes. He is a chef. He's standing on his feet all day. So there is that amount of pressure. So he's exudating. And for the purposes of this specific case study, he doesn't have an infection. So we're going to look at a simple exudating wound without an infection. So why is exudate a problem for Ali? If the volume of exudate becomes excessive, there is a risk of peri-wound maceration. So you can see that white tissue surrounding the wound, causing further excoriation of the surrounding skin and breakdown. So too much fluid really causes further tissue breakdown. And failure to manage high volumes of exudate could also render the wound, increase our risk of infection. And then, of course, the reduced quality of life due to leaking, discomfort, and possible malodor. So for him, this is becoming a problem and causing the wound to deteriorate rapidly and uncomfortable because there's a lot of leakage also in his shoes. So, and what we do know from evidence to date is that unmanaged, improperly managed wound exudate can be very problematic for different chronic wound types. So, for instance, in conditions like diabetic foot ulcers, increased exudate and improper management was linked to outcomes such as amputations. Certainly for pressure ulcers, we saw increased deterioration. And for venous leg ulcers as well. And there was a lot of evidence around increasing wound size, pain, and healing times. With regards to surgical wounds, again, improper or poor exudate management resulted in prolonged healing time, patient discomfort, and potential for rehospitalization. And then when it came to skin tear, again, the work done by Dr. LeBlanc has demonstrated prolonged healing time, more frequent dressing changes, increasing risk of medical adhesive related skin injury. And, again, with atypical wounds, they were associated with odor, pain, discomfort, potential for wound deterioration. So as you can see, improper management or of exudate management in chronic wounds has been linked to poor outcomes and delayed wound healing. So it is something that there is a strong need to address. And for us as clinicians and as biotechnology experts, we really have to address and tackle this. It's a very important area in the area of chronic or hard to heal wounds. So for Ali, as I move on to treat Ali, so I have addressed him systematically. I have identified what the problem is with Ali. Like, his main symptom that brings him to clinic is certainly the increase in wound exudate. So that's been problematic for him at work, with the shoes he's wearing, with the quality of life that he's leading. So I want, in my traditional standard of care, to make sure that I address his metabolic control and his comorbidities. So those have to be addressed. He has good glycemic control, but his other comorbidities, hypertension, is poorly controlled. So we will address that, because we are always, whenever we do wound care, we always say we want to treat the whole patient, not just the hole in the patient. So that's really important to address him in a holistic approach. We want to manage the local wound care, and obviously the draining is a primary area. If there's any treatment of infection, or I have to rule out osteomyelitis, which again, for Ali's case, he doesn't have it. Restoration of vascular perfusion. If that wound doesn't have adequate vascular supply, no matter what I do to Ali, it's unlikely to heal. So, but in Ali's case, he has good vascular perfusion. So I'm really happy with that. And last but not least is, as I'm doing all of this to treat the pressure, this wound is on the plantar aspect of his metatarsal phalangeal joint. It's an area of high pressure. It's an area where, as he is walking in the propulsive phase of gait, he needs to toe off. So it's an important and critical area to take the pressure off, so that the cells can heal adequately in the right environment. And then when I look closely at preparing that wound bed, I want to cleanse that wound, so clean it. I want to debride it. So as you could see from my previous image, for me to be able to treat that, you could see all of that dead and callous skin has to be removed. It has to be surgically debrided. So that's very important. I have to make sure that the bacterial balance is adequate, rule out and treat superficial or spreading systemic infection. So again, in the case of Ali, he doesn't have an infection, but I have to rule it out, and I have to have an index of suspicion for infection. And then last but not least, balance the moisture. As we mentioned earlier, the wound can't be too dry and it can't be too wet. It has to be the right environment for the for the cells to be able to replicate. So now I'm going to move on to dressings. And dressings are key to managing fluid. And they do that by absorbing it and or allowing it to evaporate from that dressing surface. So selecting the right dressing is really critical for me. And when we look at this chart, we can see there are many dressings that you could be looking at, and it depends on the amount of exudate that you have. So obviously, if the wound is not heavily exudating, you can look at cotton, polyester, viscose fibers. You can look at semi-permeable films. But as the exudate starts to increase, you have to look at things that are more able to absorb more fluids, like the foams, like the hydrocolloids, like the alginate. So the super absorbents, all of these are the different categories. And there are lots of tools out there that indicate which dressing category you should be looking at. And for the purposes of this case study and for the amount of exudate that Ali has, my clinical decision was to move with foams because he has sufficient amount of drainage and it is non-infected. So my clinical decision was to move with a foam dressing in that case. So absorbent dressings, many dressings absorb and allow moisture to evaporate from the outer surface. Dressings made from cotton, viscous, polyester that we talked about, and some simple foam dressings absorb fluids and hold it in places within that dressing material. When placed under pressure, unfortunately, the fluid can be released from the spaces and leak out of the dressing. Some dressings, like hydrocolloids, alginates, cadexamer, methyl cellulose fibers, and super absorbent dressings absorb fluid to form a gel-like material. And when placed under high pressures, the gel can change shape, but it retains the fluid and it reduces lateral tracking. Many dressings can allow moisture to evaporate from many of those specifically absorbent dressings can allow moisture to evaporate from their outer surface. And this obvious characteristic can be quantified as the moisture vapor transmission rate. Dressings with this high moisture vapor transmitting rate may be useful in managing exudate, where minimal bulk is really preferable. So whenever I'm, as a clinician, selecting a dressing, it's important that there are many dressings, but for me as a clinician, when I'm selecting it and when you're designing it, we need to use something that's easy to apply. It ideally doesn't require a second dressing. It's comfortable. It reduces pain and certainly doesn't cause pain on application. Comfort, as we mentioned, is really important. It's conformable. So you see with Ali, it's at the bottom of the foot. If it doesn't conform to that anatomy, then it becomes problematic. Then it's moving around everywhere in the shoe and creating new sets of problems. It's important that when I select a dressing that I make sure that it can prevent leakages. If there's odor, that it absorbs odor, it stays intact and it remains in place during wear. It is suitable for that extended wear. So we don't want to be changing dressings too frequently for multiple reasons. Some partly the cost effectiveness of it, as well as disturbing that healing wound bed is causing disruption and not allowing the cells to migrate and replicate properly. So we want to leave the dressing intact and in place for the recommended duration. It's suitable for fluid handling capacity. It retains fluid handling capacity. It's unlikely to cause sensitization or provoke an allergic reaction. It's cosmetically acceptable. That's a big thing for our patients. It does not impede physical activities. So again, at the bottom of the foot, that will be something that selecting the right dressing is really critical. Patients can shower with the dressing. Many times for our patients, with multiple dressings, we ask them to apply a saran wrap on it. And as I mentioned, cost effective. So there are multiple factors that we are looking at. So we want to take a closer look at foam dressings. So we're going to look specifically, the choice for Ali was a foam dressing. So what I want to do is I want to look, and these are areas that you're probably a lot more proficient in than I am. I'm coming at this as a clinician, and I'll tell you what I'm looking for, but this is your area of expertise where we need to look at mechanical performance, stiffness, conformability, swelling characteristics, and mechanical protection of that foam. So when we look at foam structure and function of the foam, foam dressings are commonly made of soft polyurethane, which is often treated in various ways to create that hydrophilic, non-adherent membrane. This allows the passage of exudate through to the insulating foam body of the dressing. Foam have many important advantages as wound dressing materials over traditional textile dressings or hydrocolloid dressings, mainly because of their superior fluid absorbency and lower risk to adhere to that fragile wound bed tissues. And I always want to remind you that when the wound bed is prepared and it's ready to start the wound, to start the healing process, those cells are like baby cells. We want to protect them. We don't want anything to stick on them. If it adheres, you're just yanking out fresh cells that are ready to proliferate. So we don't want anything to be adhering or sticking to that wound bed. So that's why foam dressings are actually quite superior in that area and quite superior in the area of non-adhering. Foams are also preferred for their mechanical cushioning properly, except obviously if you put too many layers, then you're neutralizing the effect. Thermal insulation of the wound is also another feature of foams, and the flexibility to conform to relatively well to curved body contours is another feature of foams. So that's another thing is, remember when I said to you with Ali, his wound is on the first metatarsal phalangeal joint. So I needed a dressing that would conform to that area and that wouldn't be moving around. Maintenance of a moist wound healing environment. So obviously this wound is exudating. It's not over exudating. So maintenance, so with the foam dressing, it would maintain the adequate moist wound environment. And of course, the quality and of the clinical performance of foam-based dressing stem from the microstructure and the properties of the specific foam types used in dressings. So that's the structure and form of foam. The stiffness of foam is really another important areas that have to be factors. Foam in wound dressings are composed of the solid polymer phase and dispersed air phase. They offer storage space for excess exudate, which is the case for us and with Ali. We need them to be lightweight and have the ability to absorb mechanical energy through deformation, which promotes mechanical protection and cushioning abilities. It also supports to facilitate a good thermal insulation of the wound bed against heat loss to the ambient environment. So especially since we have tissue loss and loss of the epidermis, it's designed to optimize these mechanical properties, balancing between stiffness and conformability determined by the foam density. Ideally, the ideal foams is that they have a stiffness level that is similar to our skin. So we don't want it to be too stiff, and we don't want it to be over flexible and really low. And we also want the foam type of dressing to practice, to function under mechanical deformation and repetitive loading. So an average person takes 4,000 to 5,000 steps. So with Ali, that's a lot of steps. And especially with him being a chef, that's a lot of pressure. So we need foam type dressing, foams in foam dressings, particularly when subjected to body weight loads or under compression, may be deformed to substantially larger strains. And we have to make sure that it's the right type of foam that can take this amount of pressure that is being impacted on, especially recognizing where we're using it, which is on the plantar aspect of the foot. And of course, what we also want to make sure is the bending stiffness. The bending stiffness of foams used in wound dressing is important in the context of mechanical protection provided by dressings to the wound bed and peri-wound tissues. And the conformability of the applied dressings to the curved body surfaces and its ease of use to avoid mechanical resistance to applying it on the convex body surfaces, and for us, like the first metatarsal phalangeal joint. Greater bending stiffness may cause discomfort to some of our patients. So if the dressing is placed on a body part that is relatively, and make it difficult to apply the dressing on the curved body surface. So we don't want it too stiff, because that could become problematic for us and it would increase some of that pressure. The added flexibility of dressing by means the foam material contributes to the dressing wastage through enhanced capacity to remain in place for as long as needed. So conformability, as we mentioned, is a really important thing, and it's an important feature of the foam material to the wound shape, but needs to not overstress the wound because of the swelling and the dilation as the dressing absorbs that exudate fluid. But what we have to make sure that, the amount of drainage that's in there is not causing its own localized pressure at the center of the wound and creating other breakdown due to that absorption that's taking place. So addressing material with a high volume capacity storage could have the potential of negative effects of dilatation in a confined wound space, causing that localized pressure increase on that delicate wound bed that we talked about, leading then to tissue breakdown and stress and concentration on the wound bed. So then you're creating your own sets of pressure through that feature. So again, it's that striking that balance with the wound dressing and the specific foam dressing. So what we wanted to do in the ideal wound dressing is we want to be looking at the compressive material stiffness. If it's too low, it can have compromised physical mechanical protection to the wound bed against external forces. It can create extreme deformation under external loads, leading to potentially low durability and dressing disintegration, which will not help us. And if it's excessively high, we then risk the risk of imprinting and peri-wound skin, increasing the inflammatory response and then damaging the peri-wound viability, which then can compromise wound healing. And it could also lead to low conformability, curved body surfaces, and increased likelihood of dressing detachment. And when it comes to the structural end and the bending and the stiffness, what we don't want to do is to have it too low, because that would result in compromised physical mechanical protection to the wound bed against external forces and impacts. And it could create extreme deformation under external loads, leading to potentially low durability and dressing disintegration, which compromises the wound healing. And when it comes, and if it's excessively high, we also risk imprinting the peri-wound skin and low conformability. And as well, we want to make sure that the adhesive strength is not too low or too high. If it's too low, that will render us to be forced to have frequent dressing detachments, exposing the wounds on a regular basis, which is not ideal, and leading to the likelihood of greater infections. And if it's too high, well, we risk developing a medical adhesive related skin injury, which is, again, not ideal. So it has to be the right strength to prevent us from running into things that could compromise our wound outcomes. So in summary, some of the take-home message: foam dressings are most commonly made of soft polyurethane treated to create a hydrophilic, non-adherent membrane. It allows the passage of exudate through to the insulating foam body of the dressing. It's recognized for fluid absorbency and lower risk to adhere to fragile wound bed if used in the right clinical context. It's preferred for its mechanical cushioning properties, thermal insulations, flexibility to conform to relatively well to curved body contours, and it helps maintain for us that nice, moist, interactive wound healing environment. And then all key aspects of the mechanical performance of foams within foam-based wound dressings depend on the microstructure of that foam, the compressive and tensile stiffness and strength of foams affecting the ability of dressings to protect the wound mechanically, and bending stiffness of foams influences the conformability performance of foam-based dressings. All depend on that relative density and propensity of the foam materials. There is, as we've discussed, a variability in the microstructural properties reflected in the published studies, leading to high variabilities in foam stiffness, strength, conformability, performance, and durability of foam. So remember, not all foams are equal, and you have to select the right type for the right wound, for the right body location. And all of these factors are critical for delivering adequate mechanical protection to the wound bed and peri-wound bed, which we want to protect because once you prepare the wound bed, it's really fragile, and you want to make sure that the dressing is not causing secondary damage within that intended period. So that's in summary our case that we've looked at and the dressings that we've looked at. I also want to take a couple of moments and tell you about Wounds Canada and some of the resources that you can access that are online and ready for you. So Wounds Canada, we're a charitable organization dedicated to advancing wound care in Canada. We're a knowledge network connected to multiple other knowledge networks. So we're part of the knowledge industry area in wound care. We deliver professional education. We support public advocacy, awareness, and education. We support research, and we partnered with many organizations such as yourself to improve patient outcome and advance wound care. Wounds Canada can offer you an opportunity to be part of the Canadian wound care community, learn and build your wound care knowledge and skills. We have conferences, training institutes, multiple resources that you can access online free of charge that are things like best practice recommendations, patient tools published in multiple languages. So lots of resources. It allows, we also have 2 publications. So we're always looking for great and innovative research. So if you're working on innovative products that have been trialed and you want to submit in for publications, we look forward to that. And it also gives you an opportunity to become an advocate and foster leadership opportunities. Many reasons. There are many people that are members of our organization. This year, we have 2023, we have virtual and hybrid events taking place across Canada. And we look forward to having you participate if this is an area of interest. We also have a competency-based institute to advance wound care knowledge. And as I said, lots of best practices, 2 open access publications, and lots of clinical resources that can help you. So if you're trying to wonder what to put on a wound, how to match it, what kind of devices exist, all of these, you'll find it on our website if you're interested in this area of study. And of course, we are active on social media like many other organizations. So follow us and tweet. And I hope by the end of this session, you've had the opportunity to understand the benefits and drawbacks of wound exudate, discuss the management of wound exudate in person living with diabetes, summarize the characteristics of foam dressings, recognize resources that are available for your work to support you to advance your practice. Thank you.
Bismillahirrahmanirrahim. Thank you very much, Dr. MARIAM, BOTROS, for your interesting and engaging topics. So I think now I would like to open for Q&A sessions. So okay, so for the first questions, okay, so from Puan Maizatu Akmal here. Okay, thank you for the sharing, Dr. MARIAM. So I have a question here. Is the foam-based materials are suitable for all age?
Yes, they're supposed to be, suitable for all ages for patients that have a wound that is indicated for that foam dressing. So it's very dependent on the clinical assessment and diagnosis.
Okay, so okay, thank you, Dr. MARIAM. Okay, so then we have a second question from Dr. Nohayati Muhammad Noor. So, hi, doctor. I've seen this kind of wound from my family member due to diabetes on her heels. So the wound almost amputated her, but luckily with proper diet, wound dressing, antimicrobial patch, it has improved the healing of the wound so much. So very informative and nice talk. Thank you so much, doctor.
Thank you. Thank you. And heel diabetic foot wounds are very difficult to treat. And as I said earlier in the talk, always with diabetic foot ulcers, we have to have the index of suspicion that they are infected. So I'm glad that you addressed that case and managed it appropriately.
Okay, so next from Ida Madiha. So dear doctor, thank you for nice sharing. So I would like to ask, what is the most important consideration for dressing selections?
So remember what we talked about. It's really matching that patient assessment, your goals with the appropriate type of dressing. So there are many cases, depending on what type of wound it is, where it's located, where it's situated, what kind of drainage is taking place, what stage it's at, patient goals, patient preferences, and matching it with appropriate dressing to support the right preparation of the wound bed. So obviously, if it's an ischemic wound, you don't want to be donating moisture to it. But if it is a wound that you are ready to dress and it's ready to heal, so you want to have the right moisture level. And there are many dressing selections out there that can support it. If it's a wound that's stooled and you want to expedite its healing, you might want to go, and it's hard to heal wound, you might want to look at some of the advanced therapies. So the answer is it depends.
Okay, thank you. Thank you, doctor. Okay, so next will be from Muhammad Amirul. How are you, doctor? So okay, so doctor, is the true if the diabetic patient has to undergo amputation, say up to the time, the life chances is no more than 5 years?
So the survival rate, is this what the question is asking? Yes, the survival rate post amputation can be quite narrow, up to 5 years. Yes, that is correct. So obviously, we want most amputations are 85% of amputations are preventable. So the more upstream that we work and the more active we are as a multidisciplinary team to heal healable wounds, we have a better chance of preventing amputations and preventing mortality. It can be prevented in most cases, but it's about timely care. It's about aggressive wound care management and medical management.
Okay. So then next, well, we have lots of questions here. So very engaging sessions, I think. So next from Zawiya. So what is your opinion if use herbal-based ingredient as complementary treatments to heal the wounds?
So you're using the herbal base. So again, I'm trying to understand the question. So you're using the herbal as an oral treatment besides wound care? Is that what the question is?
I think the question is we put the herbal to the wound area. Some kinds like from like medicinal plants, so we put the herbals piece, for example, like that to the wound area.
So again, my answer always is it really depends. I mean, on your clinical assessment, on the patient preference, on the patient goals, on what you have identified when you've prepared the wound bed, and it depends on that herbal medicinal treatment that you're using. Are you using it as an antimicrobial? So there isn't a simple answer that I can provide. There are many dressings out there, and some patient preferences are to use these products. But again, it really depends within your assessment and your diagnosis of the case.
Okay. So then next, so the next question is from Madam Suryani. So what is the advice for diabetic patients to undergo medical surgery? So how he or she is supposed to do to treat his or her wounds?
Sorry, can you repeat the question again?
Okay, so the question is, what is the advice for diabetic patient to undergo medical surgery? So how he or she is supposed to do to treat his or her wounds?
Okay, so as I mentioned, it's really important in your assessment if you've identified the need for surgical intervention and revascularization. That's key. We could never heal that wound without the appropriate surgical or medical intervention. Because as we mentioned in the talk, we're treating the whole patient, and the whole patient is connected to a whole system that if the surgical components are warranted, it needs to happen.
Okay. So next from Lina. So Lina said that thank you very much for this sharing. So what are the factors that trigger or initiates the wound developments for diabetic patients?
So what are the factors that trigger the wounds?
Yes.
Okay, so in patients with diabetes, it's what we call and we know as that unholy triad. It's the diabetic foot disease that renders the person prone to developing diabetic foot ulcers or things like neuropathy. So the loss of a protective sensation is key. So that patient is unable to detect the injury. The changes in the vascular system, peripheral arterial disease. So when the vascular system is compromised, that's another big factor as a complication of diabetes. So that's another thing. And as well, that person is also prone to the development of neuropathy associated with the diabetes. So all of those and deformity puts that person's foot at high risk of pressure. So that's another factor. And then high glycemic levels also render that patient to have immunopathy. So if they do develop an infection, they're unable to fight it. So combine all these factors, they leave that patient prone to the development of a diabetic foot ulcer.
Okay, so
Farah, are you there?
yes, I'm here. It's only that I think that the line's a bit lag. Okay, so we have a next question from Madam Razanta. Okay, so she thanks for the very informative talk. So she wants to know what kind of material is used in producing a good form for the wounds.
Can you repeat the question? Sorry, I didn't hear that.
So she asks, what kind of material is used in producing a good form for the wounds?
What kind of materials are used?
I think yes, materials that can produce a good forms for the wounds.
So there are different types of materials that can be used as wound dressings. Is that what the question is?
Yes. She wants to know what kind of materials that can be good for wounds.
Oh, okay. Sorry. Okay. Thank you so much. So as we talked, it's made out of polyurethane. So that's what it's made out of. And so that's what they use to make foam dressings out of.
Okay, thank you. Okay, so so since that I've already raised all of the questions, so I have a questions. Myself, I have a question for you, doctor. So I'm wondering, like, as I saw that in one of your slides, you did mention that the wounds need to have very good environment, which is it cannot be too dry or too moist, so, or too wet. So I'm just wondering what happens if it's too dry or if it's too wet?
It won't heal.
I see.
So you need the right wound moisture level to allow moist interactive healing, to allow the cells to replicate. So it's that incubator that you're keeping that wound in. And if it's not in the right pH levels, if it's not in the right moisture levels, the cells are not, you're not forming the right environment for the cells to replicate. So, so it's critical for that to happen. As I mentioned, if it's too wet, then what happens? You get the maceration, you get the additional breakdown, you get all the other complications. And if it's too dry, you're not going to get cell migration taking place because it's too dry. And the wound dries and cracks and it won't heal properly and in an efficient time.
So it means that we need to control the environments with a proper parameters to make sure the wounds can heal on time, right?
Correct.
Okay, thank you very much, doctor. Okay, so thank you very much, Dr. Mariam BOTROS, for sharing her expertise in wound management, and also thanks to the audience for all of the questions given. So, and I'm sure that all of the audience learns a lot today and have lots of take-home message from the talks today. So with this, I return the session to our IBD Director, Prof. Dr. Hisham El-Henshasi.
Thank you very much, Dr. Siti Paulina, for the excellent handling of the Q&A session. And very special thanks and big applause for Dr. Mariam for her excellent presentation, which is very informative. And I think it's touching everyday's life for all of us. Some people, they have family member or friends or neighbors, they have diabetics, they have wound problems, and now become a big issue, especially if it's got infected with non-curable or microbial resistance for antibiotics and all those issues. I think it's also a hot topic here in IBD. And in the group of Dr. Siti Paulina and Dr. Noor Izian, we have two experts for the skins and cosmetics and cosmeceutics. I believe your lecture is just a start for long-term collaboration with Wound Canada and yourself. Maybe in the future, I'm looking for more collaboration and contact from the team and yourself to have maybe CSR programs in collaborations in Malaysia. Could be virtual, online, but I love to have this message dispersed as much as we can for many people. Among the audience also, I'm thankful for everyone who came for this session today. We have people also from industry or our also industrial partners. We were looking for your lecture and for have collaboration with IBD and you as well for special dressing, for herbal-based antimicrobial dressing as well with the team. And with this, I'm very happy to say very nice, successful. And you keep you now until 10:30 evening in Canada. Thank you very much. That's you came for this session after a long day. But again, thank you very much, Dr. Mariam. And we're looking to welcome you again face to face in the near future. Thank you.
Thank you. Thank you so much. It's a real honor and privilege to be with all of you. Thank you so much. Thank you.